Hello and welcome to Aspen and Arbor's documentation standards for evaluations, research, and discharges. So we're talking about this at this point in time because the quality of what we do is so important. Our evals, our research, and our discharges at this time really need to reflect the best of our clinical judgment and show the individualized care that we provide. So when we're thinking about that, we need to look at a lot of different dimensions. When we have solid documentation, it's going to help us get approval for more therapy from those managed care companies that want to cut people. If we can objectively show solid functional gains, we're more likely to get a little bit more time with these people. It's going to protect our licenses. So we know that if it's not documented, it didn't happen. And so we need to make sure that we've got a careful record of exactly what all interventions we're providing, what safety measures we have in place. We want to make sure that we protect our licensure, as well as we need to make sure that we are abiding by our standards of practice for our professions. We do have those ethics and integrity benchmarks that we need to abide by, and solid documentation will support that. We also want to show the sophistication of the care that we're providing. Each of us have college degrees, and we want our documentation to reflect the intelligence of our clinical decisions and judgments and show our smarts on paper. So we want our documentation to reflect our solid, good clinical judgment and why we went to school. When we do those things, we're going to have a less risk of denial. We're going to have a better chance for getting reimbursed for our services. You know, you're getting a paycheck, and obviously our facilities, our customers, our employers want their paycheck too. So we need to support that with, again, the quality of our documentation. It's going to protect us from a liability standpoint. We know that there's a lot of concerns about resident abuse and the ways that skilled nursing facilities at times may mishandle the residents they're entrusted to care for. We want to make sure our documentation is going to absolutely support that we are providing the best level of care possible. And we need to have solid team communication. And when we have good documentation, I think it's really good for the interdisciplinary team to be able to work together and know just what all is going on with each other while we're treating the same individual. So breaking it down to the evaluation itself, we're going to be looking at, we have to have that primary diagnosis listed for on the top ICD-10 listing. That primary diagnosis needs to come from nursing. In addition to that, there may be times when it's appropriate to add one or two other diagnoses that will support the plan of care. And this can be particularly important for speech therapy referrals. When we're treating somebody with a hip fracture, they don't necessarily need speech therapy. So adding into that top listing of the ICD-10 codes, the fact that they also have dementia or resulting dysphagia from intubation or those kinds of issues, we want to make sure that we're popping up those ICD-10 codes that will best support why we're picking them up for that plan of care. For OT and PT, adding any relevant neuro or ortho diagnosis fortifies that plan of care. And for speech therapy, adding in any relevant neuro diagnosis would fortify that plan of care. In the reason for referral, we need to explain why therapy is appropriate now, especially for our long-term care residents. We want to know what's changed. We want to relate those functional changes to any kind of medical diagnosis when appropriate. So if there's been an exacerbation of MS, or if they've had a recent decline due to an exacerbation of dementia, we want to connect those dots in that reason for referral. Self-referrals, if a person comes to you saying they want to walk better, have a regular diet, toilet themselves, we need to justify why it's appropriate to pick them up. We know everybody would like to be potentially more self-sufficient, so we need to explain why in our clinical judgment it's appropriate to evaluate them at this point in time. So it's okay to put that the person has self-referred for therapy, but then explain why in your clinical judgment it's appropriate to evaluate them. And we need to include any kind of recent diagnosis that's going to impact rehab as part of that reason for referral. So sometimes it can be the effect of the comorbidities on their current functional status. Sometimes the best thing we can say is that they've had prolonged hospitalization and bed rest resulting in weakness, when the reason they were hospitalized isn't necessarily really obviously linked to one of our more traditional rehab needs. So with the prior level of function, again, it's going to be their recent best ability to function. And if we're going to make a goal for that area, it cannot be not applicable or did not test. We need to have that valid prior level of function. Otherwise, Medicare could come back and say, how do you know that they're not already at their prior level if you didn't test it? So we need to give solid information for that. We need to try to find that prior level of function. We know it's easy if it's in the chart, in the forms that come over from the hospital, or if it's in the EMR, but sometimes we have to document that it's per patient report or based on their reported prior living environment. And so we have to kind of extrapolate. Well, they told me they were independent with everything, even if you sometimes question that, but we can qualify it by saying it's what the person's told you. We need to have the prior level of function support the goal levels that we're establishing. So we need to have a prior level that's going to be reasonable for the goals that we're writing, or we need to justify why it's appropriate to go above their recent prior level of function. So CMS says you really can't get them any better than their recent best ability to function. We know sometimes we can if we give them a walker, if they have better fitting dentures, all those kinds of things, we can advance them. So we just need to justify and clarify the information. Remember that that prior level of function is not the status that was upon their most recent discharge back to the hospital. So if they've come in, they've gone out, now they're coming back. You want to look back far enough for that prior level of function to support the highest level of goal achievement that you think is reasonable for that person. If we're going to go above that prior level, again, we can use explanations such as new medications, there's new equipment in place, there's been a change in their physical or mental status, increased alertness, wound healing, weight-bearing status. We just want to make sure we document those things to justify going above their prior level. The next area that we look at when we're going through the body of the evaluation would be our baselines. And so we know that we have to have a baseline for every goal, okay? We can't just pick a goal and not have it be validated with a baseline in the body of the evaluation itself. Your evaluative findings are where you're determining that there's issues to write a goal for. So make sure that that information is reflected in the body of the eval. And sometimes that means if you're going to write a custom goal, you might have to grab one of those little pieces of paper that's off to the right-hand side of an area that you're looking at. And maybe it's range of motion and you want to write a custom goal for range of motion. So you'll need to grab that piece of paper and write in some information that would provide that baseline level, okay? Remember, if you have not applicable or did not test, that's not a valid baseline for a goal because again, CMS is going to say, how do you know they're not already at that status if you didn't assess it or it was not applicable? If we have a baseline of dependent or unable, that does enable us to show goal progression. So if it's from pain or fear or fatigue, and they decline, for example, doing a transfer with you on day one, or they don't want to eat anything to show you their swallowing skills, again, in that moment, they are unable or dependent, and we can take them from dependent to min-assist or 90% safe or whatever it might be. Those are better baselines than did not test, okay? We want to make sure that we have some logic with what we're documenting. So we know range of motion standards and we know manual muscle testing for those of us who are PTs or OTs. So if you're documenting that they have 75% full range of motion, then it doesn't make sense for their strength to be 3 out of 5, unless you explain that their power is 3 out of 5 within available range. Just make sure it's logical. Again, poor dynamic standing balance doesn't make sense that they are standby assist with transfers. So make sure you explain those things. And standardized testing is so, so important. Get that objective information from the get-go so that you have that as a solid evidence-based part of your practice. When we're looking at section GG, and there's whole webinars and training available for you on section GG, but as a brief recap, remember that we need to score all GG areas per your discipline upon admission and upon a planned discharge if the admission or discharge scoring is happening within 3 days of admission or discharge. We want to use the net health subcategories to help support GG coding. So we want to use those breakout areas such as footwear versus lower body dressing, rolling in bed versus sit to supine or supine to sit. Quick, easy clicks, but you've right away got supportive documentation because sometimes they may be one level for rolling or for lower body dressing and a different level for footwear or supine to sit. So quickly you'll have supportive information if you just use those breakout areas, okay? The subcategories. Make sure again that you double check for logic or explain those discrepancies. So for example, if you're documenting bed mobility as a 0.9, not applicable upon evaluation, make sure that that's correct or you explain it. They slept in a recliner. Maybe somebody with quadriplegia doesn't do any bed mobility types of things. Make sure you explain discrepancies, like if you're going to code a transfer as a 2, meaning it's a max assist, but their contact guard for 10 feet of gait, that might be a disconnect. So you make sure that you explain any of those apparent discrepancies or correct if it's an error. And make sure that you consider writing a plan of care goal or including in your goals areas to focus upon, such as walking on uneven surfaces, navigating up and down a curb one step, car transfers, or picking up an item. So sometimes those can be incorporated into your functional transfer goal to include car transfers, or community mobility to include curbs and uneven surfaces. We know that people are going to have to navigate these things if they go out to a doctor's appointment, go out with a family member. So we want to ensure that that's been addressed in that plan of care because, again, we're the experts on training for these areas. We don't want to overlook something that might be appropriate for that person. With speech therapists and PDPM support, remember we need to provide that BIMS screening score to support their cognitive status. And we probably would also have to do some additional cognitive assessments to support cognitive deficits. So if the BIMS results is a 13 or 14 out of 15 or 15 out of 15, we know that they don't qualify for having a cognitive deficit according to the PDPM standards. We still may say that they have a cognitive deficit, and we would want to have some supportive evidence-based testing for that. So it might be a SLUMS or a MOCA, the GDS, whichever it might be, but give some additional testing to support your findings of there being a cognitive deficit. Make sure that you complete the Section C and Section K worksheets. If you've got questions about that, certainly talk to your FRC or an additional area manager, regional director, director of clinical compliance. We're all happy to help you get information for that. And make sure that you're being accurate with your scoring. It's so important at this point, especially with PDPM now, we're getting under the microscope because we want to make sure that we aren't appearing to misquote or misscore somebody that might artificially inflate their case mix index, which would artificially inflate reimbursement. So they're looking at us to make sure that we're being accurate. So accuracy is key right now. And I think that as speech therapists, you guys are truly the experts at providing standardized testing. You probably do a lot more of them than nursing or social work ever does. And you know the importance of sticking to the script when you're providing any of your standardized tests. The BIMS is no different, so I would support that we're going to do a really good job with accurately scoring a BIMS. We want to give that information to nursing or social work, okay? With regards to the goals that we write, we know that they need to be measurable and functional. Once in a while, I still do see non-measurable or non-functional goals, so double check yourself with that. Making sure that your goals for pain or range of motion, those kinds of areas, also have a functional component. So for example, you might need to decrease pain to no more than 3 out of 5 to enable lower body dressing. So there's a functional component, and yet it's measurable. We know that in net health, we need to have at least one short-term and one long-term goal, and they should not repeat. So we can have a long-term goal, for example, for caregiver education, and we can have it measurable, such as caregiver will demonstrate good competence with splint donning and doffing, or the caregiver is going to be 100% accurate with, for example, safe swallow cues, that type of information. Remember that having a goal for us to assess or test a specific area or us to provide a customized wheelchair assessment, those kinds of goals are not necessarily patient-driven. Those are goals of what we're going to do, not what the patient's going to do. So we need to eliminate writing those kind of goals. It's okay to have a standardized test goal be a part of the plan of care. So for example, you can have a goal for the person to score at least 25 out of 28 on the Tinetti to enable safe ad-lib mobility within the facility. That's all fine. But to have a goal for will assess Tinetti, will assess for customized wheelchair, that is not a patient-driven measurable functional goal. So we need to avoid writing those kinds of areas. With our evaluation codes for the OTs and PTs that are listening, remember that we have information about the accurate use of OT and PT evaluation codes, both on our website under the employee portal, as well as the APTA AOT website to have a lot of information about accurate coding. Remember that the person needs to qualify for the complexity rating in all of those areas, or they need to score out at the next lower category. So for example, if 2 areas are highly complex, 1 area is moderately complex, they would score out for that moderate complexity evaluation code. So some other final important details, excuse me, about the evaluation. Remember to click on the build box beside the clinical impressions and make sure you click on continue to complete that sentence. You always want to write a treatment encounter note that's going to support the CPT codes that you're billing for the day of an eval, a recert, or a discharge progress note. Don't just write C eval or C progress note. If you're billing for a treatment code, such as 97530 therapeutic activity, you need to explain what therapeutic activity you provided for that individual on that day of therapy. You can use the build phrases, especially for those days, because I recognize you're doing a lot of other documentation. So the build phrases can make those notes a little bit quick and easy, but you do want to make sure you're explaining what treatment you're billing for. Okay. This is a quick screenshot from point of care about the clinical impression build box. You can click on that little TXT for text box, and populate the information in. You can choose up to 3 phrases that would explain what you're doing, why you're needing that treatment frequency, and then just make sure that you click on continue. You can certainly add your own pre-typed information as well to that area, but this just helps us justify our frequency and duration. With the progress notes, so make sure that you talk to the therapy assistants that you might be working with, review their treatment encounter notes so that you've got the most current updated patient status. If you're doing a Part B progress report, for example, you want to update the goals as necessary. You need to either upgrade or downgrade the goals depending on their status. And you want to make sure that you document patient-specific skilled interventions along with using build phrases if you would choose, so that we have an individualized progress note. You shouldn't have Mrs. Jones's progress note for the first interval look like the second interval, look like the third interval. You want those progress notes to be individualized, and you don't want Mrs. Jones's progress notes to look like Mr. Green's or Mr. Brown's or anybody else's. So populate some of those free typed phrases in there about what the therapy has focused on, and that's going to help you individualize that information. The progress note needs to justify why therapy should continue. And if we don't really have a lot of changes happening, if therapy is slow to progress at this point in time, make sure you explain the delay or perhaps revise those goals. And instead of having a transfer goal, break it down to a sit to stand goal, because then we can show those gains and we can show that progress. We can enable success with smaller goals. For OTs and PTs, you want to choose a supervision phrase that indicates communication or consultation with the assistant. Again, that's going to be one of those last 5 options in the build area for supervision. And we want to make sure that we're repeating those standardized tests when appropriate so we can objectively document their status and hopefully their progression. Or if they're not making gains, we can explain that as well in terms of what might be going on with them clinically. But with standardized testing, we definitely want to make sure that we are quantifying and verifying our findings and our evidence-based practice. So again, use those standardized tests: eval, progress note, recert, discharge, okay? With our recerts, so again, we want to make sure that the data is going to justify continued therapy. We want to explain, as I've said, with the progress notes, any delays in progress or decrease in the goal status. We want to update the goals as appropriate to show their progressions. And again, when we're documenting the information for the skilled summary, the summary of skilled interventions since the last progress note, that information should not be the same as the summary since the eval. Because again, we want to make sure that what we're doing on day 30 or day 60 of therapy, it shows that we're making some progress with that person. We're not going to be doing the same interventions day 1 as day 30 or day 60. So what has treatment focused on since the last progress note or since the evaluation? Show the dynamic, skilled nature of what it is that we're providing. Show the clinical judgment that we're using. Show that clinical reasoning. Show how we've shifted up therapy, perhaps, that we initially focused on sitting balance, progressed to standing balance. We worked on pre-feeding skills. Now we're working on feeding skills, okay? So we want to make sure that we show that advancement, what we're doing to help advance that person. And that includes with caregiver training as well. So we want to document how we're progressing with caregiver training. What are we doing differently? Are they working on sliding board transfers versus stand pivot transfers, going from a stand lift to a stand pivot? How are we progressing that? With the recerts, again, remember to keep it very clear in your mind what the baselines, the prior level, and the current status would be. At times, I do see some flipped information, and I think that's just the busyness of the day, but it doesn't always make sense. You also want to keep it very clear when you're documenting in terms of percentages. So if your baseline is 50%, your goal is 0%, and then I see their current status is 90%. I'm not sure that we're really making them worse. I think we're flipping the percentages in our mind, but we might want 0% risk of falls, 0% risk of aspiration. So make sure that that 90%, is it true or is it just, again, a flipped piece of information? When we're doing a research, sometimes if we write some comments by those goal status areas, it can be very helpful to explain their maybe delayed progress. It can help justify some skilled therapy. Again, we want to also use those standardized testing. With our discharge summaries, those need to be done by the clinicians, by the OTR, by the physical therapist, speech therapist, and that's a guideline per our licensure laws as well as per CMS. So we need to have them completely own the discharge summary. That discharge summary can be our last chance to defend that episode of care. We've all seen the people that come in at mod assist, progress to min assist, decline to max assist, end up at mod assist. That whole episode of care, it doesn't look like they made many changes, but we need to explain that whole episode of care then. We need to justify the length of stay and any kind of clinical judgment for that length of stay, again, especially with those people that really waffled throughout their episode of care. And that discharge summary needs to clarify the status with goals, comments perhaps by those goals to help indicate what's been going on for that individual. We want to note the training of all that we've done and the results of that education. We want to specifically note our recommendations for that discharge with equipment, with home care, with restorative nursing programs. Be specific as to what we're referring to, and make sure that we're giving accurate data for the functional status of all known areas to support effective GG scoring and coding. We want to have strong outcomes. If we have kind of sloppy discharge GG coding, we're not going to have as strong of outcomes as we could have. And again, that's so important at this point in time with nursing home compare, with managed care companies looking at our star ratings. So we need to have and show our solid outcomes with good information. Some additional considerations: make sure you don't share your password. Make sure that you don't have an assistant start or open a document for you, because it can look like they own that document. And the documents you need to own, like PARPI progress notes, research, discharge summaries, again, you only want your name on that document. So be sure you're careful about not having them open that for you. The exception for that is that an FRC assistant can sometimes add clerical information, and it's very simple about reorganizing ICD-10 coding if MDS nurses give us more information after we've done that evaluation. Otherwise, don't have the assistants open a document. And remember that students can only create a mock document in the sandbox. They do not document in the medical record. Again, that is per CMS directives. So as a quick wrap up, remember that point of service documentation, when it's feasible, can save time at the end of the day. It enables perhaps better accuracy. It can help with resident awareness of their status. It can be a chance to review that therapy session and say, okay, what did we do today? Why did I have you playing catch? And what was the point of that? And did you realize yesterday you only stood for a couple of minutes, today you stood for 4 or 5 minutes? So it's a great chance to reflect on that therapy session, make sure they understand why they're doing what they're doing, and it enables us to have a chance to get their input for their goals, for their discharge planning, what it is they prefer to do. How can we modify tomorrow's session to be a little bit more engaging or interesting for them? Again, as we have careful, accurate informations, we're going to be protecting the residents, we're going to be protecting our licenses, the facilities, our employers. Okay, we want to be careful with accurate, solid information. If you have questions about anything I've mentioned in this webinar, you can certainly consult with your FRC, the area manager, the regional director, or your director of clinical compliance. So I thank you for your time and attention for this webinar. Take care and have a great day ahead.